All right, so we're going to get started. Okay. So I want to thank Michelle for inviting us to speak today. We're very excited to be here. I wasn't able to make it last year for the inaugural event, but excited to be here this year. Brandon did an awesome job of kind of setting the stage for, I think, today's talks, which is awesome. So I'm going to kind of build on a little bit of some of the things that he brought up and primarily talk about the assessment of autism spectrum disorder today. And we have a booth after this, so if you guys have specific questions, feel free to come see us over there in the booths. Great. So I'll say a little bit about me. So my name is Dr. Holly Quimby-Tremaine. I work at Rochester Neuropsychology Services, which is our private practice here in town. I'll talk a little bit about my education. So I first completed my undergrad degree in psychology, and then I got my master's in clinical and counseling psychology out in Philadelphia, and then stayed there and did my doctorate in clinical psychology at Widener University. After I graduated from Widener, I did my 2-year fellowship at University of Wisconsin-Madison School of Medicine, where I focused on pediatric neuropsychology during those 2 years. Throughout my education and training, I've worked in a variety of settings. So I've worked in a public school as a school psychologist. I've worked in private practice and also in outpatient hospital settings. So I'm going to take this so I can see. So the outline for our talk today, I'm going to talk about defining what autism spectrum disorder is, because in order to really talk about the assessment, you kind of need to first have an understanding of what we mean by defining autism. Then we'll talk about the key components of an autism evaluation, the benefits to pursuing an autism evaluation, different types of evaluations, standardized measures that we use in the process, and then I also included some helpful books and resources you might want to check out for more information. So first, defining autism. So similar to what Brandon mentioned earlier, most of us in the medical world use the Diagnostic and Statistical Manual for Mental Disorders, or DSM for short. And this is what most professionals use to diagnose autism. So we're currently on the DSM-5 TR, but it gets updated every so many years. So the biggest shift to the diagnostic manual when it updated was in 2013. Similar to what Brandon mentioned, that we used to have separate diagnoses for autism, for Asperger's, as well as something called pervasive developmental disorder, not otherwise specified. So they took all three of those and kind of collapsed them into the autism spectrum disorder. And so that's what we use now to classify. So there's certainly some criticism regarding the DSM because it is considered more deficit-based from a medical model and not as strengths-based. And so I wanted to kind of bring up the idea of neurodiversity. Has anyone heard that term before? Yeah, see some hands. So neurodiversity basically is the idea that we all have different brains and we all have different strengths in areas of weakness or areas of need. And so really, our world would not be what it is today if we all had the same brain, right? So we're all bringing different strengths and we all have different things that are harder for us. And so just because we have a different brain, some people feel like that shouldn't be considered a diagnosis or a disorder. So one perspective is that our world in general is not really set up for neurodiversity, but rather for what people may say are neurotypical individuals. So we don't use the word normal, but neurotypical. And that we need a label such as something like autism as a helpful term for describing somebody that has neurodivergence or neurodiversity living in a neurotypical world. So now it's kind of a mouthful, but that's one perspective that I feel like is helpful for kind of considering, why are we calling this a disorder when really, it's just a difference, and if everyone would just understand that we all have differences, we might not need the label. So some professionals have chosen to rewrite the criteria for ASD from more of a strengths-based lens. So I'm going to present one of those perspectives here today as just an example, but there's certainly many out there. So I wasn't sure how big this was going to be on the screen, but this is a professional who is in private practice who took the DSM-5 criteria and kind of mapped it on with the strengths-based criteria. So I'll highlight a few of these today so you can kind of see maybe another way of thinking about it. So for example, the DSM on the left side in the red talks about abnormal social approach and failure for back and forth conversation skills, and a more strength-based way of talking about it might be tendency to talk passionately about certain topics and not choosing to engage in small talk. So that's kind of another way of getting at, maybe the same symptoms that we might be seeing or the same, examples, but from more of a strength-based lens. A couple other examples I want to point out: deficits in nonverbal communication behaviors used for social interactions. So another way to think about it from more of a strength-based: differences in nonverbal communication, including stimming while talking, looking elsewhere, or being bored. Deficits in developing, maintaining, and understanding relationships. And then another way to think about this might be due to differences in communication, but also if neurotypical people are kind of shunning people that identify as having autism, that might be why some of those relationships are hard. So not really putting the blame on the person with the autism, but on potentially people that they're coming in contact with in the community. All right, go to the next slide. So next I'm going to talk about the current DSM-5 criteria. I think that I'm going to try not to get too bogged down by the jargon, and I'll give some examples, but I think as the audience, it's probably helpful for you to kind of hear where most evaluators are coming from when they're diagnosing potentially you or your child or somebody that you're working with, so that you kind of understand what types of questions they might be asking. So the first criteria is persistent deficits in social communication and social interaction across multiple contexts. And then they give examples as manifest by the following. So deficits in social emotional reciprocity. So I have a couple examples that I wanted to go through. I think what people generally think of is that if this is something that you or someone that is in your family struggles with, that there's like a complete lack of interest in back and forth conversations, or very disengaged, but that's not always what it looks like. So it might actually be, difficulty responding to your name if someone's calling your name, difficulty starting conversations, or knowing how much to give in that conversation versus as much to how much you should listen to the person talking with you. Also can be picking up on what we call social breadcrumbs. So, some of these kind of unwritten social rules that most people that don't identify with autism kind of pick up on, whereas people that do have maybe a harder time with that. Also, this can include having kind of like a social filter. Okay. The next is deficits in nonverbal communicative behaviors used for social interaction. So this can also be what a lot of times people think of as lack of eye contact, but there can be more than that. So if it can be, certainly can be eye contact that might be challenging, or it might be really intense eye contact where you're using it too much and not knowing when to kind of look away. It can also be your physical body in space. So whether that's standing really close to people or really far away from people. So kind of proprioception is what we call that. Next, deficits in developing, maintaining, and understanding relationships. So what sometimes people think about this is that people with autism either do not have friends or don't want to have friends, but that's not typically what I see in my practice and what I think is most people's experience. I think people with autism in general want to have these friendships and relationships, but it's just harder to kind of maintain those relationships. So maybe going from, I've had, people I've worked with in the past saying, how do I go from talking to somebody at school that's a classmate and making them a friend? So like, do I ask them to hang out? How many times do I ask them to hang out? How do I do that? And so it might be, some examples like that. Or they make friends very easily, but keeping those friends past maybe 1 or 2 play dates might be something that's more challenging. So next we'll talk about criterion B. And so this one is pretty jargony, but It's restricted and repetitive patterns of behavior, interests, or activities. And it has to be manifested by at least two of the following. So we'll walk through 4 different examples that the DSM outlines, but I wanted to make this point that they can be either current or by history. So this is a pretty big distinguisher, because we do know, and we'll talk a little bit more later about, there are certainly people that are getting diagnosed with autism later in life and might not necessarily show all of these behavioral examples, even though, like, let's say somebody is, 18 at the time of diagnosis, but and they're maybe not showing some of these behaviors, but they did when they were 6, if you talk to their parents. And so that's why it's important to know that it can be either current or by history. So we'll go through some examples. So first, talking about stereotyped or repetitive motor movements, use of objects or speech. So a lot of times what somebody might think of if they're not super familiar with autism is hand flapping or behavioral movements that are pretty obvious that people see, whether it's at home or at school or out in public. But there can be a wide variety. So it might be repetitively kind of like twirling your finger in your hair. It could be saying some of the same phrases over and over, not necessarily epithalamic or repeating other people, but having similar phrases that are kind of like someone's kind of go-to phrases that they say in a lot of different settings. It could also be humming, toe walking. Another example that I've seen too clinically are people choosing to engage in similar behaviors over and over. So whether that's like watching the same shows over and over or reading the same books over and over because it provides some comfort. Number 2, insistence on sameness and flexible adherence to routines or ritualized patterns of verbal or nonverbal behavior. So and some examples of this might be inflexibility in routines. So, most of us, I like to say to families when I'm working with them that nobody really likes when there's changes to our plans, right? We kind of like how things are, how they're supposed to be. But we know that, we kind of have to roll with the punches sometimes if, the weather doesn't turn out how we want it to be, or, you think you're gonna have the same teacher for the whole semester and then that person gets ill and you've got to substitute, things happen. It's kind of what we do and what our reaction is like to those changes. So in general, people with autism typically get more upset if there's changes to routines and not really knowing what to do or how to kind of adapt with those changes. This can also include perfectionism. So I think this is less thought of, but wanting things to be a certain way, black or white thinking. So a lot of our life is kind of lived in the gray, where it depends situation. But if you're more of a black or white thinker, that can be like it's either all or nothing. Either I have to have this food today, or I'm not going to eat, or I have to have this teacher, or I'm not going to go. So those are some examples of kind of being more black and white. Highly restricted and fixated interests that are abnormal in intensity or focus. So a lot of times people think about this as like boys being obsessed with Thomas the Train or maps. And we know now that that's not the only way to think about it. There's a lot of different interests that people can have, and male or female. And some examples could be really interested in animals or really interested in maps. And it's not really the interest itself that's the problem, and it's not really problematic. It's more about the intensity or focus. And so, if you really like maps, that's totally fine, but are you able to talk about other things with other peers, or can you only talk about maps? And especially if that's, something that's really your highly specified interest, that it's hard for somebody else to join in that conversation. Next are hyper and hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. So typically we see hypersensitivity to sounds, to textures of certain clothing, temperatures, But it can also be hyposensitive, meaning that you're less sensitive to some of those things too. So I feel like that's a little less common, but still could be present. One thing to also consider as an evaluator is that sometimes when I'm talking with parents, they're not always aware of some of the sensory sensitivities that their child might have. So especially in, I think, people that are more like higher maskers, we'll kind of talk about what masking is in a little bit, but it's not always obvious to people, even parents, I think. So really the importance of talking to the client themselves, no matter what their age. If your child's 8 or if they're 18 or 25, we still want to ask their perspective of, how sensitive they are to certain things. We're kind of asking about that. Okay, next are criterion C through E. So in criterion C, the symptoms must be present in the early developmental period, but may not present until social demands exceed limited capacities. So what the first part of this is referring to is that typically autism spectrum disorder would be diagnosed before either between birth and age 18, so before you become an adult. However, we're realizing now that there are more people that have kind of shown signs of autism in the developmental period. It just wasn't obvious to everybody else around them. So they may have not been diagnosed before 18, but might be coming in for diagnosis at like 22 or 25 with a history of these concerns. So what this is trying to get at is that, we typically wouldn't see all of a sudden characteristics of autism at like 35 if we've never seen it before, even some of the examples, even if they were more mild when they were younger. D, symptoms cause clinically significant impairment in social settings, occupational or work settings, or other important areas of functioning. So this is also a little controversial, but really in order to make a diagnosis, there has to be some impairment present. So it's not really just like you're checking off a box of noticing these symptoms, but really how are they impacting the individual's life? So are they getting in the way of relationships? Are they getting in the way of school performance, of being able to be in the classroom? Are they getting in the way at home with interactions with parents, with siblings, in the workplace as well? And E, these disturbances are not better explained by an intellectual disability or global developmental delay. So this one's a little tricky because you can have an intellectual disability and autism, but what the evaluator wanted to make sure is that the social communication deficits and behaviors are below what we expected given an IQ. So for example, with intellectual disability, we expect that there's certain behavioral and social challenges, but with autism, we would expect them to be more than what we would expect with intellectual disability alone. Okay. So as a continued part of the criteria, the evaluator should also specify the severity. So the severity is based on both the social communication impairments as well as the restricted or repetitive patterns of behavior. And so the severity levels range from level 1, requiring least support, to level 3, needing higher support. And I believe the purpose of including this in the 2013 revision was to kind of be able to parse out people that were before meeting criteria under autism and the people that were meeting criteria under Asperger's. Typically, even though there's similarities in behavior, which is why they were kind of folded into the same diagnosis, there's usually pretty different needs in terms of everyday needs of amount of support in those two camps. So an example of someone that would qualify under like a level 3 needing high support might be somebody who either due to their communication style, whether they're nonverbal or are not able to communicate their needs, might need to have an adult with them in order to go out into the community or participate, at school or at work. Whereas somebody with level 1 that requires least support might be somebody that, if they choose not to share their diagnosis of autism, somebody might not even know that they have autism if they're able to independently go to their place of employment or school without people knowing unless they really knew them pretty well. And then next you'd specify with or without intellectual impairment. So this is where if there was a diagnosis of intellectual disability, you would note that with or without accompanying language impairment. So as part of evaluation, we always are looking at language skills. So specifying that as well. And then associated with a known medical or genetic condition or environmental factor. So we do know that certain genetic conditions and medical conditions have a higher likelihood of autism, similar to what Brandon talked about earlier. But for example, people with congenital heart disease have a higher likelihood of autism. Same with genetic condition 22q deletion syndrome is another one that's known to be associated with autism. And then you also specify if they're associated with another neurodevelopmental, mental, or behavioral disorder. So typically, when I'm evaluating somebody with autism, not always, but usually there are other factors at play too. So whether that's ADHD being also diagnosed, anxiety disorders, depressive disorders, sometimes behavioral disorders too, can be associated with autism. And it's important to really parse out the differences because depending on the condition that you have or the number of conditions you have, that really guides treatment. So, you know, the treatment for ADHD is not necessarily the same treatment for autism. So that's why important diagnoses, why it's important to get that right. So in general, symptoms are usually recognized during the second year of life, but can be seen earlier than the first year of life if we see severe developmental delays. So typically when you're going to your appointments with your pediatrician, like your well child visits that you're going to when your child's very young, they're going to be asking about developmental milestones and if your child is meeting those, because those can be kind of red flags for autism. So early signs might be early developmental delays or any loss of social skills or language skills. So what that means is, you know, your child may have been picking up on words, but then either lost the words that they had or not making progress as expected. Behavioral features can also become evident in early childhood, where you might see a child that's not interested in interacting with other peers, or they might not be interested in playing with parents, doing kind of like the early play-based skills. Symptoms can become more obvious once the demands for socialization exceed their capacity. So for example, some people you know, look pretty typical when they're playing with kids when they're a lot younger, but then when they get to adolescence or as a young adult, when they have to use more nuanced social skills, that's where we sometimes see these deficits coming out that might not have been present from the early developmental period. So other examples of early signs of ASD, these can include significant behavioral tantrums, difficulty soothing, showing some lack of affection. There might be limited empathy or feeling very self-focused. So it's important to note that these are just some examples, not certainly everyone's presentation. And these are really non-specific behaviors. So they can be part of a lot of different reasons, which is why an accurate diagnosis I think is important. And that just because your child is having a tantrum does not mean they have autism, but you know, these are just kind of examples that help figure out, you know, if this is something we should be exploring. There also might be delays in gross and fine motor skills, struggling with direct gaze, so being able to, you know, look up at their mother, father, or caregiver, social smiling, showing you something of interest. So being able to take something that they're interested in playing with and kind of taking that and showing another person. There might be a lack of that, or sharing possessions, lack of interest in same age peers. So sometimes kids are either really interested in playing with a lot developmentally younger children than them, or only interested in being around adults. Those are also some examples. Something called parallel play, which is where instead of playing with another child or somebody in their house, but playing next to somebody or alongside somebody. So, you know, if I'm playing with blocks, but then my child's playing with another toy right next to me, but not necessarily interested in playing with me. Last, unusual speech. echolalia, which is kind of repeating back what other people are saying, unusual tone or volume, rhythm in speech. So this might look like, or might sound like being very monotone or not really a lot of inflection in their voice. Next, I'll talk about late diagnosis of ASD. So this is becoming more and more common as people are realizing that the autism spectrum is a wider spectrum than we originally thought. So again, I wanted to mention that you can diagnose partially based on history. So, this is where it's really important to have what we call a collateral report. So like if I'm evaluating somebody that's 19 or 21, it's helpful typically to have their parents as part of the evaluation if they're consenting to that, because it's hard for us to think back on when we were 3 or 5 or 7 years old of what we were like at home. We kind of need to have that parent input to see what based on their memory. You still need to meet clinical criteria per the DSM, but it might be more of a nuanced presentation. So this means that the person evaluating probably needs to spend a significant amount of time with this individual if it's something that is more nuanced and harder to kind of tell without diving deep into these criteria. Remember that how you evaluate for ASD can really impact whether or not you meet criteria. So I've had people come to my office and say that, their pediatrician, who they see maybe once a year or every couple of years for 20 minutes, thinks that, if they tell them that I have a concern my child has autism, they might say, oh, I don't see that. Like they're in my office and they've talked to me or they looked at me, then that means they don't have autism. So that's, like a very gross example of like just one perspective, but school evaluations, it depends too if the person is functioning very well at school, then maybe the school team might not be concerned about something like autism, whereas the parents might be seeing a lot more at home. That's kind of leading them to think that. Autism can also run in families, so parent report can sometimes be skewed. And so what I mean by that is that it really, when you're asking people about certain behaviors or things they're seeing at home, it really depends on your frame of reference. So if these are certain things that you as a parent have struggled with, whether it's like maintaining relationships or if you have multiple children that have autism, your lens might be skewed a little bit towards somebody that either doesn't struggle with those same things or doesn't have other children with autism. The idea of masking symptoms. So has everyone heard of that term, masking? Some people, okay. So masking is the idea that people with autism have some of these examples that we're talking about as part of autism, but they're able to kind of pass or kind of go through certain situations, whether that's at school or at work or with peers, kind of mimicking typical behavior that other people that do not have autism are able to demonstrate. And so we see this a lot, specifically in females, that they're able to kind of mimic either from watching shows or from other friends that they can kind of make themselves pass, and so that people are not realizing that they're struggling with certain things because they're able to kind of look neurotypical in regular settings. And in general, the literature has shown us that females with ASD tend to be diagnosed later compared to males. And so this is kind of following the trend in the literature in the ADHD world, where when we first thought about ADHD, people kind of think of like a hyperactive 7-year-old boy. And now we've realized that ADHD can really look vastly different, especially if you're a girl, especially if you only have the inattentive symptoms and not the hyperactive impulsive symptoms. So we're starting to notice that with autism as well. So right now the criteria is still the same, but there are a lot of researchers in the field that are really trying to get at, what the more female experience of autism might look like. So next we'll talk about the key components of an ASD evaluation. So first it should include a comprehensive clinical interview. So the clinical interview should include the professional that's doing the diagnosis or the evaluation, parents or caregivers, as well as the client. I say depending on the age, in that I always do a clinical interview, but sometimes I will meet with the parents or caregivers first, and then I'll also interview the client depending on their age, either separately or all together at another time too. There should also be extensive behavioral observations of the client, so not just 15 or 20 minutes in an office visit, but typically, at least how I do my evaluations, I'm spending almost a full day with each client, and then I'm able to kind of see how does this person perform in the morning? How do they do at lunch? How do they do before they need a break? Or if they get a break, what is it like, afterwards, after that break? How do they do when tasks are really easy for them versus when things are really hard, and kind of that frustration tolerance that comes out. In my opinion, that way I can get a better idea of what a typical school day might look like or a typical work day, so I can kind of speak to that in my recommendations. Next, an evaluation should include objective measures of cognitive functioning. So this includes and can include like intellectual testing, language testing, visual testing, learning and memory, academic achievement, social cognition, as well as adaptive functioning. And so objective measures of these areas helps give us information regarding comparing your child to other people their age. So that way we're getting using normative data for the US population to compare how they're doing on some of these tests. And this helps give us information on cognitive areas of strength, which I think are always important to highlight, and especially for intervention planning. And then also areas of weakness or areas that we might want to improve in, for example, like an IEP. Next includes standardized behavioral rating scales. So these are typically completed by parents, teachers, and therapists. And so standardized behavioral rating scales get at certain behaviors that we see at home or at school, and then again compare them to other kids and other people their age that we are comparing to the same normative sample. Lastly, the evaluation should also include review of relevant medical records, educational records, as well as any other prior assessments. Okay, so some examples of benefits to pursuing an evaluation. So early diagnosis can certainly pave the way for early intervention. It may improve your child's communication as well as social development. So there are a lot of services out there that you can access if you have a very early diagnosis. So, in Minnesota, we have something called the Help Me Grow program, which, provides services if you qualify in like speech therapy, occupational therapy, physical therapy. Other early intervention can also, hook up the parents in the school or the child with their school team, even before they start school, before they start kindergarten, depending on their age. I think another benefit to pursuing an evaluation is having a framework to explain behavior, why certain situations are hard for the client and family. I think this is pretty self-explanatory, but I think it can be really helpful to feel like you're not the only one that might struggle with some of these things, and that there are other people out there that are similar. Another benefit to pursuing an evaluation is access to medical services, financial programs, certain legal protections. I believe there's going to be a speaker later today talking about that. Educational services as well as community programs. So there's a lot of interventions and services out there, but many of them require a diagnosis in order to be eligible. Another example of another benefit is kind of like a sense of belonging or identity and finding your tribe of people. I have a lot of resources I'm going to share at the end that kind of talk about this, that it can be really helpful to feel like you're not on your own, not an isolating experience, that there are other people with similar needs as you. And I think it can be really helpful to find these people either online or in meeting up in real life too, to connect. A formal evaluation can also identify co-occurring conditions. So like we spoke about earlier, if there is something like ADHD or a learning disability, cognitive giftedness, anxiety or depression, or any other condition that might go along with autism, it can be important to be able to identify that, and so that way you can also get the intervention that you or your child may need. So next we're going to talk about different types of ASD evaluations. So first I'll talk about screening assessments. So typically screening assessments happen in your child's pediatrician's office or family medicine visit. And so some of the measures that they may include are something called the MCHAT, or the Modified Checklist for Autism in Toddlers. And so my understanding, I don't give these in my clinic, but from my understanding, the MCHAT is given to all children when you're going in for these appointments when your kids are toddlers. And if there are certain items that get flagged, meaning that they rise to the level of the concern of your provider, they may refer you for a more comprehensive assessment. Same thing with the ages and stages questionnaire. This is a pretty popular measure that's given in primary care or pediatricians' offices. So my point of including this is that a screening assessment typically is not going to be something that will diagnose autism alone by just this checklist, but it's just meant as a screener, which is a first step before going to the next evaluation. Next, we'll talk about school-based assessments. So these can look really different depending on the school that your child attends, whether they go to a public school or a private school, also depending where they are in the United States. I've seen different types of school-based assessments depending on where I've trained. But typically these are psychoeducational evaluations that are necessary for school services such as an IEP or a 504 plan. So if you've heard these terminologies before, you cannot get an IEP or a 504 plan in place unless you have an evaluation done by the school. So even if you saw an outside evaluator at your child's doctor, the school would still need to do some type of evaluation in order to provide an IEP or a 504 plan. It's important to note that schools cannot provide medical diagnoses, but make an educational classification. So this is kind of tricky when parents have called me and said that, my child's classified under autism at school, but they don't have a medical diagnosis, so I can't, get services for whatever they're looking for potentially because the school has identified it, but it hasn't been identified in more of like a medical setting. And schools all are under their own discretion of, what types of assessments, or what types of measures they use to classify. There's not one, one size fits all standard that they have to use. So I've seen, I'm going to talk about a little bit later, but I've seen some schools use the ADOS, which is one of our measures we use for autism, but some schools do not have the means to do that. And so it really depends depending on the school your child goes to. Medical-based assessment may include a clinical interview with parents or caregivers, observing the child in their office, but typically this doesn't include any cognitive testing. So this might be conducted with a pediatrician or a developmental pediatrician, which is a specialist in neurodevelopmental disorders such as autism and ADHD. But they are not typically including cognitive testing, meaning that they're not going to look at something like an intellectual disability or look at the child's individual cognitive profile. Mental health-based assessments might include a clinical interview with parents and caregivers, as well as the client, observing the child of the client, and then might also include behavioral rating scales. But this also typically does not include cognitive testing. And then a comprehensive evaluation or comprehensive assessment might be something like a psychological or a neuropsychological evaluation. And this is what I provide at my office, where it includes a clinical interview, objective cognitive testing, social cognition testing, behavioral rating scales, extensive behavioral observations, as well as review of medical and school records. So I listed here a few examples of standardized measures of social cognition. And so one that most people are probably familiar with is the ADOS-2, which is the Autism Diagnostic Observation Schedule. I'm going to talk through this in a little more detail, but this is one example. It's often referred to as the gold standard in autism assessment. However, I think it's important to note that you do not need to have an ADOS in order to diagnose somebody with autism. So if you haven't had that, but you have a diagnosis, that is fine. It's not something that's required. There's also something that's new called the Monteiro Interview Guidelines for Diagnosing the Autism Spectrum, or the MIGDAS for short. So this is a measure that I'm not trained on and I don't use currently, but it's becoming more and more popular as a new assessment measure for autism. There's the Autism Diagnostic Rating Scale, or the ADIR. This is a very long clinical interview that's typically conducted with somebody who's a clinician as well as the parents, but it's usually used more in research settings, primarily because I think it takes several hours to administer. And as part of my assessment, I have a lot of other things I'm looking at too, so it doesn't really fit into my battery, but it's common at other institutions. And then something called the Behavioral Observation of Symptoms of Autism, or the BOSA. This, I believe, was developed during COVID when we weren't able to have kids come into the office for safety reasons. And so I believe this was developed as like a telehealth option, which I think was really nice at that time, certainly, especially if people cannot get into the clinic, but certainly has some limitations. So I put up a picture here of the ADOS, so you can see it in the top right corner. It's a very large bin with a lot of toys, a lot of manipulatives. So in our office, I believe it's the size of this table, maybe a little smaller, but there's a lot of different, what we call like manipulatives or toys in here, because the ADOS has 4 different modules, they call them, of different types of the test that range depending on the child and the client's age, as well as their developmental level and language skills. So some strengths of the ADOS are that it's a great tool for teaching what features and behaviors to look for and what the evaluator is looking for at that time. It's research-based and standardized, and that you're not, even though there's toys, we're not just playing with the child, but we have a purpose for what we're doing and why we're presenting certain toys. It also helps identify strengths, so areas that the child or the client does very well as areas of weakness or areas that we can work on an intervention. It helps with treatment planning. Some insurances do require this test in order to access services, which is kind of a whole nother topic, but I know there's some insurance plans that require the ADOS, which I think can be a barrier for a lot of people, but yeah, so that's, I guess, an example of one of the strengths of the test. Some of the limitations, it can be kind of artificial in that this is not a real world setting. So anytime we're doing an evaluation where someone's coming into my office, that's certainly not their everyday life. So coming into an office, whether you're at a doctor's office, might induce some anxiety for certain people. Just the thought of being evaluated too might change all of us to make our behavior a little bit different. It also requires a lot of training to administer it correctly. So when I did my ADOS training, it was 3 full days of sitting in a room like this to do the training. And then you also have to get practice administering it, having somebody watch you administer it to make sure you're doing it correctly. So it certainly takes a lot of resources in order to become proficient on this measure. So if we're requiring that, on the one hand, it's good to be proficient and know how you're administering it. However, if it takes so many resources, then it means it's that much harder for us to get a lot of providers that can administer this test. This is not magical, and it can lead to incorrectly ruling out or ruling in autism. So this is where some of the criticism has come for calling it a gold standard for assessing for autism, and that it's not like if you just give the ADOS and it says you have autism, then you have it. It's just one source of information that we use as part of a much broader array of information. It's not always accessible or realistic for every professional to administer it for the reasons that we just outlined, but so if we're requiring people to have access to the ADOS in order to diagnose, then that's going to be really tricky if you can't find somebody that can give the ADOS. Some other criticism is that some people feel like it's not very accurate in capturing ASD symptoms in females and those that are gifted, in young adults, or adults with high masking abilities. Sometimes people feel that some of the tasks that we're asking people to do as part of the ADOS are more juvenile. So if we're giving it to someone who's 20 or 22, it might feel like, why am I playing with some of these toys? And they don't all include toys, but there's certainly some aspects that some people feel like are more juvenile. So next we'll talk about behavioral rating scales. So even though these are norm referenced, they are subjective to the person completing the form or their perspective. So what this looks like are typically, paper measures that have certain symptoms, and they'll ask the parent if, you're seeing them at home and how often are you seeing some of these behaviors. And so, all of us are prone to either sometimes overrate symptoms and feel like we're seeing tons of these examples at home, or underreport symptoms depending on your other children you might have at home or your other frame of reference, and can depend on a variety of factors. So if we're only relying on rating scales, we might miss people who truly meet criteria depending on some of these factors. So I included some examples down below. I use the SRS in my practice, but there's many different examples that look at autism behaviors. So lastly, I wanted to include some helpful books and resources. So I have some of these books at my booth if you're interested in kind of paging through them. But first I'll talk about the books and I'll talk about the websites. But the first two, Parent's Guide to High Functioning Autism Spectrum Disorder, as well as Parenting a Child with Autism. These were both written by parents and professionals who both, I believe, have children that have autism, but also are professionals in this area. So I feel like there's really great vignettes or kind of examples of parenting situations that are in the books, and then also kind of talks about navigating certain services, school services, doctor's offices, and kind of looking at autism across the lifespan. The other two that are titled Is This Autism? Are both new books that just came out a few months ago from a couple of professionals in the field. And the green one talks about really understanding more of the nuanced presentation of autism that kind of gives the group of people that may or may not have met criteria as a young child, but are meeting criteria in adolescence or young adulthood. And then also talks about kind of the experience of living with autism. So some of the authors identify as having autism and kind of talk about their experience too, which I think is really helpful. And then the blue one, Is This Autism, talks more about the diagnosis of autism for clinicians. So especially people that might be therapists in their room or educators that might feel like, autism is not necessarily my area of specialty, but I have clients or students that have autism and want to learn a little bit more about it. That's a really great reference too. So the websites I included, the two YouTube videos are kind of talking about understanding the autism experience if you recently were diagnosed. And then the bottom three resources are networks that were also founded by people that have autism that kind of talk about different resources and programs and things that are available throughout the country, and I believe throughout the world. Some of them are also located in other countries. So wanted to include those as resources, so we'll leave that up here if people want to write it down. But if you have any specific questions, feel free to come see us at the booth. We'll take questions there. And I think that's it. So thank you.